When let me go to healthcare financing,
yes,
because that's really the elephant, you know, in terms of where we are today with NHIF, the public deployment of resources, private health insurance, and the whole of that scale. As has been said here, last year we spent in total public, out-of-pocket insurance close to 550 billion on health. Now, when you say we need a mixed system, you say those who can afford private insurance should continue, should be allowed.
Yes.
And then the people in NHIF should go to public hospitals. Isn't it possible to make it seamless and continuous? Isn't it possible for us, for example, to say, if you are on a private insurance of 80,000 a year,
yeah,
it's possible for that private provider to cede whatever it is, 20,000
yes,
of the 80,000
yes,
to NHIF.
Agreed.
To provide the base.
Yes.
And then the next levels of engagement, as you climb up the ladder of health provision, then the insurance can pick it up from there. So that we do not have two sets. We have one set, but it is continuous, seamless, but structured.
I see.
Don't you think
it's a good suggestion. Let me give you a collaborative proposal. Let's say I'm paying 80,000 for private insurance and I give a levy of 20,000. I want to just use your same argument. Or let's say I call it the fee. And we have, say, 3 million people in private insurance here. And if we divide it by 47 counties, that amount of money that we could get from them as a levy could help 47 counties sponsor the people who are not members of NHIF. So, you know, what I wanted to think of, I don't know the exact numbers, but it's something that I want to speak with David. If we got enough money for the people who can afford. In a county, there are two types of people. There are types of people who are employed and are members of current NHIF, sorted out. But DP, there are many people who are not members of NHIF. To me, that's your priority. A country will be judged by the people, by the system that looks after the vulnerable. How do we get the people who are not members of NHIF to be covered or to get care? The dual system I was thinking of was, you were saying, let the basic be the standard and then let it be a continuous system. That's one approach. The second approach is, let it be separate systems, both public and private. I also want NHIF members to go to private. Let them choose. In fact, let them vote with their feet. That way the public sector will become better. But let the private sector pay a certain fee that will help many of the people who are not members of NHIF to get a fund. 47 counties. I'm trying to figure that out. And so we have more people who are covered and are catered for into the system. And those who are not members will end up going for primary health care anyway, which is tax-funded system. If you make our clinics fantastic, like you said, dispensaries, so there's no lack of doctors, where you are looking at health centers, believe me, you will put pressure on the private sector. Because as government pulls up its socks, we have to pull up our socks. And the whole system will go up.
Iwapo unapenda habari nazokuletea, basi subscribe kwenye channel hii ili uwe unapata uhondo kila wakati. Shukran.